from all of our speakers. There was an excellent overview and some very different perspectives, I think very helpful perspectives on some of the realities of implementation. We are going to have time for question and answer. We do have a microphone that we will take down to anybody who has a question. If you could just let us know who you are. I also wanted to let the audience know that all of our forums, the transcripts are available on our website a couple of days after the actual forum, so if there's any part of it that you missed or if you want to let somebody else know about it, you can find it on our website. I wanted to start with the first question, if that's all right. There was a number of things that were mentioned by each one of the speakers about some of the critical parts of implementation. Some of them included the seamlessness of transitioning people between public and private insurance programs. There was also discussion about undocumented immigrants and how they are not part of federal health reform. There was talk about the importance of the individual mandate for people to have insurance coverage and whether we'll be successful in getting people to actually comply with that mandate. And health planning was another thing that was mentioned by Assemblyman Morelle. I was wondering if each one of the speakers could just share their thoughts, given all those different challenges, which of those you think is one of the most important. I won't hold you to one. Maybe you have two that you really like that you think are things that New York really needs to get right to help ensure smooth implementation. You don't mind that. We'll start with you.
To me, I think the key challenge. I think the key challenge is related to the seamlessness of how do we go from people who have very little income to up to 400% and make that work. Because again, the numbers are such that it's that group of below 400% where most of the new potential for getting expanded coverage is going to be. And if we get bogged down in complexity about 100% of poverty versus 175% of poverty, I just think people are going to be uninsured. And interestingly, that mostly affects primary care and prevention, which leads to higher costs down the line. Because what happens if you're bogged down in enrollment systems, you tend to just collapse and not get enrolled, and you don't have good access to primary care. If you do have to go to the hospitals figure out how to get you enrolled, one way or the other. So to me, it's that seamlessness that is the most important.
I think the seamlessness is definitely a difficult issue, but the more I think about it, I think that the structural issue with regard to ownership of this responsibility at the state level and how it parcels out the responsibilities to the counties and within the state is, if you get that right and you get the right leadership in place, I think you can resolve the rest of the issues successfully. If you get that wrong and decisions don't get made and there's a sharing of responsibility and there's not a central point of contact or it isn't clearly delineated, we might get other things wrong as a result. But the seamlessness is, from an operations standpoint, in the city of New York also.
I think the seamless, I hate to repeat what the other panelists have said, but if we truly want to go from, as I think it was described perhaps by Governor Spitzer, but if not, someone was talking about sort of patient-centric care and moving away from sort of institutionalized or the other kinds of ways that we define the system. If we're really truly going to make it patient-centric, then we have to devise systems that follow people literally from cradle to grave, and then no matter what setting they're in, we have access to electronic medical records. You can sort of follow people through it. I spent some time as the owner of a software development company. We built databases, so I sort of this unnatural fascination with data and capturing it and looking at it and exception reports and all that kind of good stuff. So your experiences tend to color you, but if you truly want to follow people, have better outcomes, really reduce costs, look at it, then I think developing that, recognizing the limitations because of privacy considerations, HIPAA, just the notion of Big Brother. But there's a lot we can do to build systems that sort of become truly patient-centric, and then we might be able to shift away from sort of sick care to wellness and well-being, and really try to drive people's behavior towards a wellness lifestyle.
Very good answers. At this point, I want to see if anybody had questions from the audience. Or my next question relates to, since we're talking about seamlessness, and I do see some people here in the audience who are in the field of long-term care, long-term care was not really a central issue of the legislation. There is a part of it called the Class Act related to long-term care insurance. And this somewhat relates to your point about patient-centered care. But I was wondering if the speakers would comment on how they see the long-term care system being better integrated into some of these reforms.
Well, one of the things that I've tried to promote in the legislation, and a number of proposals which we've advanced, would put greater, first of all, on the cost side and how we pay for it, try to take some of the burden off Medicaid and some of the burden that ultimately accrues on the property taxpayers, et cetera, is to have to utilize long-term care insurance to a much greater degree. It's just that when people tend to go looking for it, kids are out of college now, and so you've just gone through paying for education, et cetera. But you're 52, 53, 54 years old. The cost is still relatively high, and when if you start to focus out of your 60s, it becomes almost prohibitive. And so we have to do a much better job of creating incentives and making the cost so that people are more inclined to pay for it. I also think, we have a New York partnership program, which I think we've probably changed the name yet again on it, but in conjunction with the federal government, we don't have reciprocity. There's no more portability on the programs in New York. They are in some of the other states, so we've tried to get the health department, insurance department to understand that portability would be very, very important to try to create these reciprocity agreements. But this is obviously a critically important issue. And long-term care is not only institutionalized care, but in-home services and other things where we can hopefully keep people in their homes and keep them independent for as long as possible. It takes real effort, and unfortunately right now, basically we're just paying for it by letting people become Medicaid eligible, and it's costing tens of billions of dollars a year.
I'd just say a couple things. So I really like the class program. It's a very small program, but it's an interesting start. And it's an opt-out program, so you're automatically in it. You have to sort of pay a little bit monthly, and then you're eligible. And one thing I like about it is that it's a cash benefit you're eligible for. So when you become frail, you get a cash payment, and you can use that cash however you think is best. So it really is patient-centered. It puts the power in the patient's hands. And in other states, we find that people with a little bit of money stretch it a great deal and stay off of Medicaid. And I think that class it's too tiny in terms of its maximum benefit. But I think over time it could be added. And I think it'd be easy for the state to have some provisions that let you add to class and put some extra money in a tax deductible way, which would be expanded. And then the other part of the legislation is about encouraging more community-based long-term care and providing some demonstration dollars and some incentive dollars to this. I think there's more in here that could affect long-term care than we might imagine.
I would only add that the good thing about these panels is even when you're panelists, you learn something. And Dr. Knickman indicated that there were some policy changes concerning what's permitted to be covered in home care that is new to us. And given the fact that in New York City we have a fairly robust home health care program covering thousands of New Yorkers, the idea that we might lose some of the funding for that or support for that from the federal government is a real challenge for us to take on. So that would be hard to disentangle ourselves from.
I think these are new additional services. I don't think they're threatening that.
Hi, I'm Beverly Grossman from the Community Healthcare Association of New York State. And in a prior life, I sat with Commissioner Doar when we were doing welfare reform at the Eleanor Roosevelt.
Oh, yeah.
You remember those days? Yeah. And I have to say that model was great. It brought advocates together to talk about welfare reform and what that was going to look like in New York State and what were our bottom lines, and then brought in policy wonks and state government I think we did it for 6 months and a beautiful landscape, which was helps too. But I was very happy, Commissioner Doar, that you talked about workforce, and I think that's a piece that is easily lost. And what we know is that all the way from medical assistants to primary care docs, we don't have the workforce to actually implement the goals of healthcare reform as far as access goes. And one of the things I think is going to be challenging, and I think we really need to put our brains together about is there are new opportunities in healthcare reform around residency programs in community health centers, National Health Service Corps, those kinds of things. But I think we need to look at what are the barriers we have in New York State to getting those dollars out and moving from a real hospital-based residency idea to a community-based residency. And I'm just curious what you think we could do or have conversations about with that.
Well, I can report that at the briefing that we had with the deputy mayor and the staffs of the various city agencies, this was the one, right after seamlessness and a couple other things, was the top issue of concern. For me, I only really know on one side of it, the entry-level position area right above that, because as an agency that does welfare reform policy, that's our focus. And the healthcare industry has been enormously successful and helpful to us over the years in being a place for people to go into and be joined the workforce. That's no question about that, and we've benefited from that. Higher up the income status or residency or docs, that's not my world, but you're absolutely right. That appears to be a really great concern and something that I think we'll have to look at. I don't know the answer to how we keep more doctors in New York State. I don't think the answer, and I don't want to be facetious. In fact, I won't even snake that comment. So
I think everybody's wondering what that comment was.
To me, the issue is, I think what healthcare in the next 20, 30 years is going to be about is managing chronic illness. And it's an ambulatory thing, it's a community thing. And you take health reform, which is going to push that, and then you take aging of our society. And so we probably have to have a strategy around working with our medical schools to get more of the people we're paying as taxpayers to train to focus on some of those issues. And I think that is going to be a crisis. The other side of the lower wage part of the market, I think is really important because I think, again, as part of managing chronic illness, you need community health workers, you need case managers, and those are some of those entry-level people who you care about in terms of poverty and moving into the mainstream. Our foundation is funding something at Columbia University to try and normalize the community health worker field and professionalize it a little bit and have standards and definitions that would improve the likelihood of it getting reimbursed. So I think it is, you have to work at both ends for this to work. And nurses, of course, are crucial, and getting more nurses to be trained to work in long-term care settings and community-based settings as opposed to hospitals is the other challenge.
Question in the back.
Oh, okay. Bill Reynolds from Reynolds Consulting Group. I haven't heard anything today about mental health services, and typically you don't in these discussions because that's another silo, and mental health obviously connects into every other kind of health behavior and what people need to successfully manage chronic disease and so forth. So, what do you have to say?
I'll talk a little bit if you want. Like everything, this bill has a little bit of something for all. And there are a number of mental health provisions. There's some encouragement to integrate mental health services with primary care services, getting back to community health centers and others, so some of that. Very grateful given our interest in integrating mental health and substance abuse. There's also some encouragement of bringing those services together and have people assess. So that's very good. So there's some, and there's some issues about how you cover mental health, which probably are not as relevant to New York State and some other states that have had worse coverage. Again, we're ahead of a place. So there are a few features, probably just enough to use it as a leverage point of saying, okay, there's demonstration money out there, there's some stimulants out there in terms of resources, and some groups ought to push that. There are some of the folks in the mental health field who are really on top of this, and I think we'll be pushing funders like ourselves and like the state government to work in that area. I welcome the push.
I agree about, in New York, obviously with Timothy's Law, we before the federal parity legislation came into view, recognized the need for comprehensive mental health care, the provision of financial support for it. I actually think one of the interesting things potentially of government consolidation of agencies is going to be bringing mental health and healthcare providers together and agencies together, partly because there's going to be, the state agencies are going to get consolidated under a new governor without regard to who the governor is. I'm pretty convinced, and in a strange way, it may actually create more integration of mental health and other healthcare services. So you may see more of that just because of the scarcity of dollars.
Has that worked in New York City where they consolidated the agencies? You think,
Well, I don't know, we didn't consolidate.
no, with the mental health and
DOH.
health and mental health.
I think it has.
It's not yours.
It's not my responsibility. In the city, HRA used to be bigger. Child welfare went off and started its own agency. Homeless Services has a separate agency, and we have the Department of Aging. I agree that given the state fiscal situation, and I think I said that I thought that if you have a lead state agency on this issue, you're going to be able to get more than if you have lots of leading state agencies, or you're trying to run away from the governor's office. That, I think, would be, whether it's consolidated or not, I think you have to find some way to shrink the decision-making process a little bit so that there's a clear accountability.
But I think that it's really crucial to look at it as one problem. We have these, you're right, we have these silos. We have a whole mental health world with certain separate clinics, a whole substance abuse world with separate clinics, and then a medical world, a medical care world. And people have all three problems, they interact together, and this is a population that's very high cost and that we don't manage as well as we could or should. So it's,
I know there's a question here, let's take one from the other room, because they don't go like that.
Actually, James Knickman, Kansas City. No surprise, I'm delighted that the focus on chronic care, discretionary care, and the other control of costs. You're doing a better job of preventing and controlling chronic disease. And it's going to take a lot of education for policymakers to understand that. New York City's far ahead of us in many ways in this area. And just give an example of the New York State budget. Tobacco control, most proven programs that most across out there have disproportionate in the last few years by over 30%. We know that drives people stops because of the increase in this industry. Just a very common that we're going to need better control. So it's going to be a long-term process of education for the policy.
people hear that.
I'll translate. I'll try to translate. It's the issue of chronic care is important, and we've cut back on tobacco prevention money as sort of an example of going in the wrong direction. And how do we deal with that? You have to answer.
I said to someone at a breakfast meeting this morning that I feel like, and I'm sure most legislators feel like this, a stern father who has to say no to every funding request from their teenagers. Look, the truth is that we just don't have the money that we've had in the past relative to do the things that we wanted to do in the past. And Peter, you bring up a great point, but there are just limits to what we do financially. It is frustrating to see, and few things make me as unhappy as when I walk past a building and I see teenagers smoking or young adults smoking. I was never a smoker. I was never really that much of a vigilante on smoking, but I've sort of become one, I guess. And to your point, Peter, I guess it takes public programs. I mean, you'd think there'd be enough information, enough data in the world, data points for people to say, okay, this is not really a good lifestyle choice, but apparently it's not enough. And obviously the tobacco cessation programs that we run at the public level, at all levels, have had an impact, a pretty dramatic impact. So hopefully we'll be able to come back to it, and hopefully the value of what we know as adults and as parents will pass down, and that you won't see a sudden increase in tobacco use. But I think it's just a function. There's a lot of things we'd like to do. We just don't have the money to be able to do it right now.
Andrew Kosky, the Home Care Association in New York State. Dr. Knickman, if I understood you correctly, you said that states will have to pay for certain benefits that are more than what is mandated by health reform, and you gave home health as an example. Do you mean that's more than what is provided under Medicaid or more than what is mandated under private insurance?
Well,
again, all this is being defined as we're sitting here, and so it keeps changing. But the issue is people who buy exchange policies, and the federal government has outlined what they think should be, the coverage limits in an exchange policy, because they're very interested in making it an affordable policy. So it's a bit stripped down relative to what we consider a normal policy here in New York State. And I can't list a whole range of benefits, but there's a number of them. I think fertility benefits and some chiropractic benefits that are just not going to be as generous in what is considered the exchange standard. And my understanding of it is if the state wants to mandate them in the exchange, it has to use state dollars to pay for whatever it's mandating beyond what the federal law says. So that's the challenge.
So the seamlessness is about retaining coverage, not necessarily retaining the same coverage.
Right, and that would be one of the interesting things. You could one day, even if you had seamlessness, you could one day be eligible for home health, and then the next day you're earning a little bit more money and you're not eligible. Right. Even if you're covered. And again, all this is being worked out. And I think that the folks in the federal government don't understand all the implications yet either, and are dancing around it. Great time for consultants.
Thanks. Captain Crowley from the Times Union. So what's the bottom line? How much did it cost if we perform in New York?
Are you talking about the administrative costs of what it's going to take to implement, or just how much more are we going to spend more as a
How much
Oh,
state?
do the state coffers as the taxpayers?
I mean, I hope, and care what you say, but I think that I would hope that we don't spend more as a state when all is said and done. That we achieve some cost savings and some reform savings, and that compensates for any expansion of Medicaid. As my numbers suggest, the expansion of Medicaid is very small, maybe only 100,000 people at most. So in other states, that's the big number. You go to Mississippi or Texas, you have huge numbers of new people in Medicaid, and eventually the state has to pay a share of that. We don't have that, so I think we have a chance of being budget neutral. And for better or worse, we have a state government with no dollars to spend. And I know someone who cares about it, so he'd like to spend more, but he can't. So I think we have a chance of doing this in a budget neutral.
I think the big challenge is going to be the number of people who are currently eligible for Medicaid and have been eligible but have not signed up. And so, I think your number was about 900,000 people. So that would be a significant cost to us, notwithstanding the fact that the federal government may increase the reimbursement rate to the state of New York, and whether that last quarter of our fiscal year under the federal government happens or not. That would be significant. If that doesn't happen, I think that's worth $1.2 billion in this current fiscal year, so that's significant. So that, I think, is the issue to some degree in terms of cost.
But I wouldn't blame health reform if they don't do that. That's almost an independent. I think we'd be facing that problem whether health reform passed or not. The economic extension. That's what you're talking about.
That's right, but to the degree to which the federal reform legislation pushes people who are currently eligible but just don't apply for whatever reason, pushes them into Medicaid, we're going to have to pay for the 900,000 or so, nearly 1 million people who will be eligible. That's a significant thing, is whether we're getting reimbursed at 57% or 50% or 60%, right? It doesn't matter. There is a percentage that the state of New York and its partners have to, in the form of local governments, will have to pay.
Yeah, I think that there was and still is some hope that there is fiscal relief coming from the federal government to pay for the costs of various programs, maybe even some enhancement. And the last thing is FMF controversy. If that gets resolved positively, that's good. But cost to government and cost to residents are two different things. So while our government may get a little greater federal support, we are facing higher taxes, and so those are costs also. And that's just another question. And the impact of those higher taxes on our state and our city are undetermined. It's an open question as to whether our taxpayers will afford it and stay in New York City, New York State, or No.
And it also has impacts on our medical schools and our hospitals, and, I think they're
And
at
there's
some risk. too.
grant opportunities, there's a lot of money opportunities. The government that looks, I think the government's laid out pretty well. We have opportunities to, thanks to some help in Washington, to get more dollars from the federal government, but there's also costs.
So I guess as taxpayers and residents, we should keep our fingers crossed and get some of that extra money, even though it's still our money in the end, but it's easier for the state to implement. I didn't see any other hands ups. Oh. Okay, no, we have one more, and then I think we'll wrap up.
Okay. A quick question. Another one of my, Bill Reynolds again, my area of interest, another area is rehabilitation services, which have typically been very limited under existing insurance plans, but also very, very necessary to have people successfully transition into back in the community.
I'm not sure how the law affects rehab per se.
Well, no, I think that, we're going through sort of an interesting conversation right now about rehabilitation and habilitation efforts as it relates to people with autism, and we're sort of looking at the question of rehabilitation and habilitation. Obviously, if it's medically necessary under the law, it's going to be covered. If it's not, then it's going to continue to be a barrier. I'm not sure that there's anything here which changes the rules relative to that, although habilitation is listed in the federal health care legislation, but I'm not sure there's many changes as it relates to whether it's medically necessary.
So I think there are still many issues to be learned about as time passes, and many things that have yet to be seen. So I think that this will not be the last forum that we have on the subject of public performance implementation. But please join me in thanking our excellent speakers and